Corpulmonale. Corpulmonale, otherwise known as right heart failure. It's an enlargement of right ventricle due to high blood pressure in the lungs, usually caused by chronic lung disease. So, in corpulmonale, alteration in the structure or function of the right ventricle resulting from the disease affecting lung structure or function or its vasculature. So, the corpulmonale means right heart failure. Okay, so here what happens? Here there will be alteration or the structural or functional alteration in the right ventricle occurs due to the etiology in the lungs. Okay, due to the lung disorders, there will be alteration in the structure and function of the right-sided heart. So that is known as the corpulmonale or right heart failure. Okay, so here in this picture you can see that dilation or stretching or hypertrophy of the ventricles, that is mainly due to the chronic lung disorders. So here there will be alteration in the function of the right-sided heart. That's why it is known as corpulmonale. Etiology of corpulmonale or causes of corpulmonale. It include lung diseases like COPD, bronchiectasis, pulmonary fibrosis, severe chronic asthma, lung resection. These are the etiology under lung diseases. Lung disease cause corpulmonale. Then pulmonary vascular diseases, pulmonary emboli, pulmonary vasculitis, primary pulmonary hypertension, sickle cell disease, parasite infestation. So, pulmonary vascular disorders, everything related to lung and its vasculatures. Okay, so pulmonary vascular disorders. Next one, thoracic cage abnormalities like kyphosis, scoliosis, then thoracoplasty. Next one, neuromuscular disorders. Neuromuscular disorders like myasthenia gravis, poliomyelitis, motor neuron disorders. So, the disorders of neuromuscular, that is myasthenia gravis, poliomyelitis and motor neuron disease. Then hypoventilation, that is sleep apnea, enlarged adenoids in children, hypoventilation disorders like sleep apnea and hypoventilation. Then cerebrovascular disorders. So cerebrovascular disorders also cause corpulmonale. So corpulmonale mainly due to lung disease and pulmonary vascular problems. Okay, and others also cause the corpulmonale, that includes the neuromuscular disorders, then cerebrovascular disorders. Hyperventilation and thoracic cage abnormality also a predisposing factor for corpulmonale. Next one, pathophysiology, corpulmonale pathophysiology. Any condition that deprives the oxygen in the lungs that leads to alveolar hypoxia. Okay, hypoxia in the lungs. So this hypoxia that leads to hypoxic pulmonary vasoconstriction. Due to hypoxia, there will be vasoconstriction. This vasoconstriction leads to increased pulmonary vascular resistance. Increased pulmonary vascular resistance that leads to pulmonary hypertension. So, in pulmonary hypertension is increased, there is increased right ventricular afterload. That's why there will be right ventricular hypertrophy and right ventricular failure that leads to corpulmonale. So, here not only alveolar hypoxia, hypoxemia, acidemia, capillary distractions, emphysema, then polycythemia, all these cause the hypoxic problems, pulmonary, increased pulmonary vascular resistance and pulmonary hypertension. So, due to various etiology, there will be hypoxic pulmonary vasoconstriction that leads to increased pulmonary vascular resistance. In case of emphysema also, there will be increased pulmonary vascular resistance. So, when there is increased pulmonary vascular resistance, that leads to pulmonary hypertension. Pulmonary hypertension, polycythemia also cause pulmonary hypertension. That's why sickle cell disease is an etiology for corpulmonale. So, when there is pulmonary hypertension is increased, there will be right ventricular afterload is increased, that leads to right ventricular hypertrophy and gradually right ventricular failure that leads to corpulmonale. So this is the pathophysiology. The clinical manifestations of right-sided heart failure or corpulmonale, the features are fatigue, increased peripheral vascular resistance, ascites, enlarged liver or spleen, otherwise we can say hepatomegaly or splenomegaly, then heart murmur, then maybe secondary to chronic pulmonary problems, there will be distended jugular veins, anorexia, complaints of GI distress, weight gain, dependent edema. Then dyspnea is the main feature for this patient. The person may the paroxysmal nocturnal dyspnea common in right-sided heart failure. Okay, due to the fluid overload. Okay, then distended neck veins, that is jugular neck veins will be distended. Then peripheral edema, usually pitting edema, both lower legs may be present. Then heart murmur is the other feature. So these all are the features of right-sided heart failure. In right-sided heart failure, the main features due to fluid accumulations. That's why there will be severe dyspnea, especially the paroxysmal nocturnal dyspnea, heart murmurs, hepatomegaly, splenomegaly, dependent edema, then peripheral edema, then ascites, pleural effusion. All these features can be seen. Then along with that, there will be GI symptoms. The diagnosis for the corpulmonale is chest radiograph, electrocardiogram or EKG, then echocardiogram, then pulmonary function test. The exact diagnosis of corpulmonale by evidence of hypertension of the pulmonary circuit. There will be pulmonary hypertension. So, in order to identify that, we can see mid-sternal or epigastric heave in X-ray, pulmonary diastolic shock, then sharply or split P2, sharp or split P2. In ECG, you can see that P waves are split or the sharp waves. Then in right ventricular enlargement in the ECG you can be observed, or also in echo right ventricular enlargement can seen. So in ECG, right axis deviation, then P tall and sharp, then high R will be high or elongated. Then radiograph also will be helpful. Then right heart failure without left heart failure, only right heart failure is present. Then the person have the pulmonary features or pulmonary problems like symptoms and signs of pulmonary disease. Then absence of significant valvular disease, systemic or hypertensive or ischemic heart disease or myocardial infarction. All these features will be absent. So when we are diagnosing corpulmonale, you have to make sure that it is not associated with heart disorders. Okay, and it should be, or it along with this corpulmonale, it should be with lung disorders. Okay, so here there will be any pulmonary etiology will be present with corpulmonale. And when you are observing ECG, here you can see the right axis deviation, then P wave changes. Then echocardiogram, you can see the right ventricular hypertrophy. Okay, so then mid-sternal or epigastric heave. All these features suggest that the patient have corpulmonale. The presence of tall peaked P waves in lead 2 is a sign of right atrial enlargement, usually due to pulmonary hypertension. So, corpulmonale can be diagnosed by ECG. Management of corpulmonale, it includes general measures, that is restrict fluid intake and restrict salt intake, avoid antiarrhythmic for asymptomatic arrhythmias, then avoid NSAIDs, then immunize against influenza or pneumococcal pneumonia, because the pneumonia and lung infections may cause corpulmonale. So that's why we will immunize the patient. Then the main management is diuretics, especially used in a volume overloaded patient to achieve normal JVP, jugular venous pressure, and relief of edema. Then we have to assess the daily weight. Then for diuretic resistance, administer IV or use two diuretics in combination, that is furosemide with metolazone. Or usually we are giving the Lasix, but it is not useful, then we can give as a combination drugs. Then low dose dopamine to enhance renal flow. Then pulmonary vasodilators also can be used. Nitroprusside, hydralazine also can be used. Then AC inhibitors or angiotensin receptor blocker for all patients with LV systolic heart failure or asymptomatic LV dysfunction, we can use the ACE inhibitors. Next one, beta blocker. Beta blocker for patients with symptomatic or asymptomatic heart failure. The contraindication is bronchospasm, symptomatic bradycardia, then heart block. All this condition, beta blocker is contraindicated. Then aldosterone antagonist. Aldosterone antagonist, especially the class 3 and class 4 heart failure, the ejection fraction, left ventricular ejection fraction less than 35%. At that time, we can use the aldosterone antagonist. Then digitalis also can be used in case of systolic heart failure, persistent systolic heart failure. That condition, we can use the digitalis. So actually, the diuretics, pulmonary vasodilators, calcium channel blockers. Calcium channel blockers, example nifedipine and deltiazem. That is very important. Then bronchodilators in patients with pulmonary etiology, definitely the beta 2 agonist is very important. The albuterol. Okay, then anticholinergics, so ipratropium bromide, nebulization drugs, especially the ipratropium bromide. Then methyl xanthines, theophylline, deriphyllin group of drugs, aminophylline, methyl xanthines, especially the bronchodilators. Okay, then other management is the chest physiotherapy in order to reduce the fluid in the chest. Okay, the chest physiotherapy that will help to cough out the sputum. So chest physiotherapy can be useful. The cough will be produced and the sputum will be spit out. Then in severe condition, we can use the mechanical ventilation. The non-mechanical ventilation or non-invasive mechanical ventilation can be used. Then sodium restriction and water restriction is very important. Then other measures, that is consider combination of hydralazine or oral nitrate if not tolerant of ACE inhibitor. Then consider ventricular resynchronization, that is biventricular pacemaker. It is biventricular pacemaker. If it is necessary only we are doing. Usually in the treatment we are not using pacemakers. The cardioverter defibrillator also in severe conditions. In normal conditions, we are not using. The main management what we are using nowadays is diuretic therapy, administration of oxygen, then the restriction of salt and water, then pulmonary vasodilators like sodium nitroprusside or hydralazines, then calcium channel blockers like nifedipine, TSM, then bronchodilators, beta 2 agonists, that is albuterol, then anticholinergics, ipratropium bromide, methyl xanthines, theophylline, etiophylline group of drugs, then mechanical ventilation in case of necessary. Okay, so these all are the medical management used for the which one? Corpulmonale. Next one, surgical management of corpulmonale, in that phlebotomy. Phlebotomy in case of polycythemia, sickle cell disease, phlebotomy had to be done because polycythemia that will be decreased by phlebotomy. Phlebotomy is indicated in patients with a chronic corpulmonale and chronic hypoxia causing severe polycythemia. Is the process of making puncture in a vein, usually in the arm, with a cannula for the purpose of drawing blood. So viscosity of the blood can be reduced. So here we are puncturing the vein and we are drawing the blood. Withdrawing the blood. So that is phlebotomy, especially in case of chronic hypoxemia due to polycythemia. Next surgical management is lung transplantation or pulmonary transplantation. It's a surgical procedure in which a patient's diseased lungs are partially or totally replaced by lungs which comes from a donor. So in lung transplantation, what we are doing is we are transplanting a donor lung in the affected part of affected lung. Okay, so here in lung transplantation we are removing the diseased lung and transplanting with a donor lung. Then regarding the complications of corpulmonale, it includes the respiratory failure and the dysrhythmias. Dysrhythmia may leads to life-threatening disease or life-threatening problems like sudden cardiac death. So here the main area we have covered is what is corpulmonale, what is the etiology of corpulmonale, what is the pathophysiology, then the clinical features, then diagnostic measures and the management of corpulmonale. Thank you.